Yeah, I got 6:02 here, so I think we're all set to go. I think we'll call this meeting to order. Natalie, if you're good. Okay. So first of all, welcome everyone. I'm glad everyone here that was able to make it. It's my pleasure to introduce not only a local expert, but actually Dr. Lalonde is an internationally recognized plastic surgeon who I've had the pleasure to work with for the last 35 years. And not to sing his accolades too much, but he's not only an educator, a plastic surgeon, but he speaks 3 languages. He's an author. And like I say, he's taught medical students for over 3 decades. Dr. Lalonde received his medical degree from Queen's University, took his plastic surgery training at McGill, and began working at the St. John Regional and St. Joseph's and Sussex in 1984. Back then with another famous surgeon by the name of Dr. Sparks, who we both remember well, Don. So not only has Don worked in St. John and surrounding areas, but he's been teaching for all that time. And something that you guys starting med school don't know, but Don has volunteered in many countries, donating his surgical skills for many patients who did not have access to healthcare. I'm hoping that he may have a few minutes to comment on those while he talks today. So the talk again is called Office Surgery for Any Doctor, and for myself and family practice who does some minor surgery, and really for anyone who's thinking of doing this going forward. We're listening to an expert talk about all the nuances and probably the most up-to-date techniques possible. So on that note, I'd like to welcome Dr. Lalonde, and thank you for coming.
Thanks very much, Dr. Simon. It's very kind of you to invite me, and I'm delighted to talk to all of those who are interested. So I want to start by talking about good local anesthesia, because that's really, really important. Until 17 years ago, I used to hurt people like crazy. In fact, for 22 years I did it. And that's because when I learned how to do these things in Montreal, the philosophy was, this is going to hurt, but not a long time, sweetheart. And it was just like, and you know, surgeons use words like they tolerate it. Yeah, that means we torture them and they let us do it, and they don't kick us and tell us we can't do it. But it doesn't have to be that way. Dr. Rob Hayes is a dermatologist who moved to St. John in 2006, and he taught me a lot about how to inject local anesthesia so it doesn't hurt. And he's doing all these cases with no sedation at all. This is called Mohs surgery. And so I spent a day with Rob, and since then I've actually done a number of research projects and written a few papers on and learned from other experts on how to do this. And so it's become a pretty good science now. And so I just want to show you, this is in my office. These are 4 patients who are waiting for their carpal tunnel surgery. And I've injected them all, and this is what it looks like. They're all, the ones who have their hand up, they've already had their local anesthesia injection for carpal tunnel surgery. And this is how you run an efficient practice in the office. If you have a number of lumps and bumps, you inject 2 or 3 of them before you start. Because if you do that, it gives the lidocaine and the epinephrine time to work. It's been well shown that it takes 26 minutes, that's level 1 evidence in humans, for epinephrine to hit the peak of its curve in vasoconstriction. It used to be thought it was 7 minutes, but that was so long. That was an old pig study from the 1980s. A human study, level 2, from the 2010s has shown us that it's 26 minutes. And also, if you wait a half an hour, the local anesthesia is going to work well. The key to good local anesthesia is put in lots, more than you need. Nobody ever complains about being too numb. And give it a long time to work. And you want to give it at least 30 minutes. And if people are on blood thinners, give it even a little longer, like 40 minutes. And it bleeds 3 times less if you wait 30 minutes after lidocaine with epinephrine injection than if you wait 7 minutes. And that was another study done by Dan McKee.
So what did you think about being awake? What would you say to your friends if they said, oh no, I really need to be asleep to have this operation done?
I didn't feel a thing. It's so quick, completely painless. Didn't
Right.
feel a thing.
And how sore was the freezing?
Very minimal. Just a tiny little pig.
There was no pain involved whatsoever, and it was quite enjoyable, actually, to be honest with you. You know, we had a nice conversation, just shooting the breeze about different stuff, and before you know it, it was done.
I enjoyed being awake so that I could watch the procedure, just no pain. Good experience.
I was thrilled to know I could be awake anyway, thinking about having it. If I thought you were going to put me to sleep, I would have worried all summer.
Why is that?
Who wants
Why-
to go to sleep? Well, you wake up and you feel like throwing up, and your nausea lasts for 24 hours, and it's terrible. So no, hands down, I'd rather be awake and have pain, but I didn't have any pain.
So these are carpal tunnel patients, but it's the same with anything. You can do facelifts this way, a little lump and bump excision, which is what you guys would probably be doing. Anything. And there's two things that people are afraid of when they have surgery. They're afraid of the pain of injection of the local anesthesia. Well, I think I've demonstrated to you these patients didn't have any pain, and I'm going to tell you exactly how we do that. And the second thing they're worried about is pain during the surgery. And if you promise them that the local anesthesia is hardly going to hurt at all, and you promise them that they're not going to have pain during the surgery, and then you deliver on those promises consistently every time, then patients are going to love you. And that's it. And when I learned how to do these things in surgery school, we put all these people to sleep. And at least 50% of Americans are still getting some kind of sedation. In other words, total body comatose instead of local, because a lot of doctors don't know how to freeze so it doesn't hurt. And mostly because they make more money doing it that way. It's a money-driven thing. It has nothing to do with patients. But if you go to the Mayo Clinic, they'll only charge you $11,000 to get you stoned. Surgery is an excuse to get high and have the same operation. So the whole thing is you don't want to be a torturer. You want patients to think you are a magician. And you want to aim for zero pain of local anesthesia, or at least only feel the first poke. And you certainly want to aim for zero pain of surgery, and you can easily achieve this. So we score all of our medical students, our residents, and me. I score myself every time I inject local anesthetics. And if patients only feel the first poke and then no pain, my medical student scores a hole in one. If the patient feels pain 2 times, my resident scores an eagle. If I make the patient feel pain 3 times, I score a birdie, or 4 times I score a bogey, or 5 times I ought to go back to medical school. Bit of a joke, but. So if you're still hurting people when you inject local anesthesia, and I often say this to old surgeons, you're never too old to stop hurting people. I learned how to stop hurting people when I was 53, so there's hope for all of us. And there are many papers written on this now. If you just want to Google my name, Lalonde, how to minimize pain of local anesthesia, or just look at pain, local anesthesia, Lalonde, and Google it, and you'll come up on this PRS Global Open paper, which has videos for each of the 13 injection points. And there's a book on wide-awake hand surgery with a whole chapter in it, and the book has over 500 videos. So we published this paper a dozen years ago, where 25 consecutive medical students and residents were taught hole-in-one local anesthesia and then scored by patients on their first carpal tunnel injection. We only use carpal tunnel because it's a pretty common thing and it's easy to teach medical students. 75% scored a hole-in-one on their first shot. 25% scored an eagle on their first shot. And 85% of the patients rated the whole pain experience as less than 1 out of 10. So you can teach anybody how to do this. Anybody can do it. If we just take a little bit longer to inject and to learn from our patients. Now, the usual causes of painful local anesthesia: injecting big volumes too fast, moving the needle too fast, and not injecting enough volume. But let's go over the 13 rules of how not to hurt people so they think you're a magician. And again, these rules are all in this open access paper in the book chapter. So rule number 1 is start with a tiny needle, 30 gauge. So, and the hospital has 30 gauge needles. And when you move to your hospital, just go find the person who orders needles, look at their order screen and go, oh, order these. These are great. If your hospital doesn't happen to have any. So I like to put a 1/2 inch 30 gauge needle on a 3 cc syringe. It's kind of my favorite starting point. Because a 1/2 inch needle lets you see how far in and out you are out of the skin, so you can see yourself drift in and out, because you want to hold your needle perfectly still when you put it in, just like a mosquito holds its proboscis perfectly still when you watch it give you a bite. It also hurts less, and it forces me to slow down. So I want to show you how I did this young man. His dog bit his nose off. And so I did him in my office on a Sunday morning.
I'd like you to take a nice deep breath, okay? And you may feel a little poke, try not to move. You might not feel anything. So 1, 2, take a deep breath. Just breathe normally.
Sneak in the fat. As soon as you're in, stop moving. As soon as you see the tissues start to inflate, stop moving your needle. The whiter my hair gets, the less I move the needle. See that? I'm not moving at all, and I put in about 2 cc's, 3 cc's. Now I go in where I've already numbed it. You never reinsert a needle in an area that's live. Now here I did get my first pain shot. He didn't feel me sneak in the fat. He did feel me get into the forehead one time. That's the only poke he felt, but I flicked my way into the forehead. So every time I reinsert, I'm going into an area that's numb. So this fellow only felt the first poke on the forehead. All of these needle reinsertions are going from an area that's already numb, and always, you know where the nerves are. You always go from where the nerves are coming from. So the supraorbital supratrochlear nerves are coming up from the eyebrow. So you start at the eyebrow and work north, because now those nerves are totally numb. And so I'm numbing up this forehead flap to reconstruct his nasal tip.
So we just got the freezing in there. I want you to tell me how sore it was.
No, it didn't hurt at all.
Okay, that's good. Compared to the dentist?
Yeah, this was nothing compared to the dentist.
Right.
Like you actually said, it's not going to hurt, and it didn't hurt. The dentist always, yeah.
You get a little poke, right?
Yeah.
And today you didn't feel a little poke? No. Great.
So, you know, we went ahead and did the forehead flap, brought it down, reconstructed the nose on the first stage.
How did you mind the surgery?
Didn't mind it at all.
Good. Good. You feeling okay now?
Good.
Not feeling nauseated at all?
No.
No.
So for this operation and a million others, we used to put people to sleep, and now we're keeping people awake. And Mike Simon mentioned that I do work in Africa. This whole concept of wide awake surgery is taking right off in Africa, because people in Africa and, you know, some countries in Southeast Asia and South America, they can't afford surgery. Not because they can't afford the surgery. They can't afford the unnecessary sedation. They can't afford getting drunk on a Saturday night to have an operation if it's not necessary. And they also can't afford main operating room sterility, which is also not necessary for many operations. And I'll talk about that in a little bit. And so this whole concept of wide awake surgery is really taking off in Africa, and it's making surgery affordable and available to many Africans who used to not be able to have it. So the second key to not hurting people is to buffer the local with bicarbonate. So the pH of lidocaine with adrenaline is 3.3 to 5.5. That's 1,000 times more acidic than the body pH of 7.4. And so if you add 1 cc of bicarbonate to each 10 cc's of local, Now the pH becomes 7.4, and it just takes a minute to do that. It's really easy to do. And bicarb's not that expensive. When you're putting in the needle, don't be a dart thrower. You know, some people hold the syringe with one hand, put it in like a dart, and then they're wobbling all over the place as they're trying to put their thumb on the plunger and grab the syringe. Don't be a dart thrower. Be a two-handed, stabilize your syringe so it's totally still, just like a mosquito is when a mosquito inserts its stinger into you. They feel I've been numbed well over 80 times. I've had digital blocks by residents and medical students. Every paper that I've ever written on local anesthesia, which is over 100, I was the first guinea pig. And so, look, I know what hurts and what doesn't hurt. I don't mind being injected by people who have no idea how to inject. And you feel every freaking little wobble until the skin is numb. So don't be a one-handed wobbler, be a two-handed stabilized injector so they don't feel any wobbles. Next is insert the needle perpendicular to the skin. So there's level 2 evidence in humans that if you come in straight up and down like on the left, that it hurts less than if you come in like this. And especially if you come in parallel to the skin, you're hitting a lot of nerve endings in the dermis. Nerves in the tree, in the skin are like trees. You got leaves in the dermis and you got trunks in the fat. So you want to inject at the trunk level, and you want to hit as few leaves on the way down to the trunk as you can. So you want to pop through the dermis. You don't want to inject in the dermis. And you want to blow in 2 cc's before you move the needle at all. So don't inject in the dermis. You're hitting more leaves in the tree. Inject under the dermis. And then put 2 cc's in there before moving the needle at all. The whiter my hair gets, the less I move the needle, period. You know, if I put 20 cc's right in there, where does it go? Everywhere. Perfect. And I do a lot of that. I just put it in, blow it up, and walk away and give it a half an hour, and that's it. So the next thing is using sensory noise. This is also very important. So sensory noise is a little bit like listening to a baby cry at the Chicago O'Hare Airport at 2 o'clock in the afternoon, or listening to the same baby cry in your bedroom at 2 o'clock in the morning. He's not crying any louder at 2 o'clock in the morning, but it sure sounds that way because there's no other noise going on. And so if you move the skin, press very firmly, just proximal to where the needle is going in. Get him to take a deep breath. Get him to listen to music, virtual reality glasses, and have the pyramids explode in the virtual reality program just as you're putting in the needle. All of these things are sensory noise. And when you do that, a lot of times the patient goes, what? I didn't feel the poke. And that's called a hole in zero when that happens. It's my favorite, and it happens to me quite a bit. So this is a hole in zero 3 times. This patient's not feeling this needle go in at all. And that's because I'm pushing the skin into the needle and I'm pinching at the same time. So I go 1, 2, 3, and my needle's getting closer and closer. And then at 3, when I pinch the skin, I'm actually pinching the skin into the needle. And then I hold that little pinch there for a minute. So this is injecting fillers with a 31 gauge needle, but you can do the same thing with a 30. So here goes.
1, 2, 3.
0.
So she
Pushing
felt
the
0
skin
pain.
into the needle instead of the needle into the skin helps a lot. 1, 2, 3.
Yeah.
Push the skin into the needle. It hurts less.
So that's what it looks like in real time. So, once you get good at this, it's like, oh my God, Dr. Lalonde, I didn't even feel that. How'd you do that? It's not hard, okay? I don't teach you guys anything hard. I'm not that smart. Everything I'm teaching you is simple. You can do this. So after you blow in 2 cc's, don't just blast it in, slow down a little bit. And never advance the sharp needle tip anywhere that's not numb, like I showed you in rapid motion and the forehead flap. So this lady, I'm going to show you injecting local anesthesia. She has lost some tendon movement. She's ruptured some tendons from rheumatoid synovitis, and she can't lift her fourth and fifth finger. So I need to take out the synovium and repair some ruptured tendons. So I'm going to inject all around 2 centimeters beyond.
Try not to move. You're going to feel a little poke. And at the count of 2, I want you to take a nice deep breath for me. Okay, so 1, take a deep breath and don't move. Great.
I'm pinching the skin.
Just breathe normally.
My syringe is stabilized on my thumb. It's not wobbling. I'm looking at my needle to make sure it's not sliding in and out. I'm staying exactly the same depth.
Well, that's good.
She says she barely felt it. Now I'm just going to speed it up 10 times. So I always reinsert 1 centimeter in behind where I have a tumescent border. The tumescent border is like a wave of local anesthesia underneath the skin. And you can tumesce large parts of the body. They're doing mastectomies in Africa. They're doing below-knee amputations in Africa. They're plating distal radius fractures all over the planet with this form of tumescent local anesthesia. So you blow it up like that. Now you can see everywhere that's numb. Walk away for half an hour, do other stuff, inject local anesthesia into other patients or do other operations, and then you come back and do it. And that's the whole, that tumescent means enough volume that you can easily see it and feel it 2 centimeters beyond any place you will insert sharp objects. And when I go to emerge and I see young residents or medical students putting in local, and I see patients wincing and going, oh, I feel that, oh, I feel that, I think, oh my God, here's another one who doesn't put in enough. It's all about volume. It's not about concentration. You don't need 2%. You only need a 0.25%. What you need is volume. You need enough that you can see it and feel it 2 centimeters beyond anywhere you're going to insert a sharp object. And there's another thing called the pink rule. Never insert a sharp object into pink skin. So once the skin has epinephrine in it, it goes white. And if there's enough epinephrine there for the skin to be white, usually there's enough lidocaine that they're not going to feel the needle go in. So never put a sharp object in pink skin. It's the pink rule.
Straighten out. See how your fingers are working pretty well there.
That's awesome. Thank you so much. It's awful when they're not working.
So the incision is buried monochrome. There's no nylon, no stitch marks, none of that foolishness. And go ahead and show us a fist again and straighten out. So for 3.5 weeks, that's excellent movement.
So doing all these cases wide awake has really improved our surgery. But the reason I show this, I wanted to show you also the incision. I'm going to show you how to do those buried 5-0 monochrome sutures so you don't have to take stitches out and so you don't leave stitch marks. So never let the needle get ahead of the local. And this is what I used to do. You can see the sharp needle tip there is boinking a nerve beyond where the blue local is. So don't do that. Instead, always have at least 1 centimeter of visible or palpable local anesthesia ahead of the needle. And look at my left index finger. It's always feeling where the tumescent border is. So my right hand is injecting, my left index is always feeling where there's local.
Great. So you didn't feel the sting of the needle go in. It's not hurting right now, right?
No.
Okay. So now blow slow before you go. Can you back up a little bit so you can see my syringe? You can see the stuff going out. Thank you. Blow slow before you go. I'm always thinking that in my head as I advance the needle tip. I always want at least 1 centimeter of visible or palpable local ahead of my sharp needle tip. Because if I just advance my needle tip into this pink area up here, she's going to feel a sting. But if I have a wheel of local anesthesia going ahead of me, then she's not going to feel a sting. Can you please tell me if you feel any sting at all in the next few minutes? Because I'm scoring myself here. And I can feel the local advance ahead of my needle tip. If you're always saying that in your head, blow slow before you go, it kind of helps you remember to be patient, because surgeons in general are impatient. We want to do everything yesterday faster, but it doesn't help patients get rid of their pain. Now I'm feeling it inflate up here, so I'm going to stop advancing my needle. Still not hurting you. You're still going to tell me, right?
Yes, I will tell you.
You're going to interrupt me, because I'm just talking to people who are learning how to put freezing in so it hurts a little less. I can feel it up here. I'm always feeling with my other hand. I can feel it all the way up here now, so we're going to be in good shape. That's going to numb that up beautifully.
So I probably put 13 in there, 3 to start out with my 30 gauge needle that she didn't feel. I scored a hole in 0 in this case. And you know, you can see the lens shaped excision. It's not really an ellipse, is it? It's more like a lens. And that's a basal cell skin cancer. And you guys can take out basal cell skin cancers in your office. 1 out of 3 white Canadians who's living past the age of 65 is getting one of these. So there's a lot of them to go around. And, you know, I love it when Mike Simon says, oh, I took off this little basal cell. I'm going, great. Especially if you can see the edge well. If you can't see the edge well, probably better to refer it. But here you can see the edge well, and you take 3 millimeters margin. And if you don't get it all, we'll fix it. But, you know, it's nice when you get it all. So the next thing is always inject from proximal to distal relative to the nerve, like the supraorbital supratrochlear nerves I showed you in the dog bite to the nose. I've already talked about reinserting. I've already talked about always inject too much volume instead of not enough volume. And make sure you can see it beyond where you're going to work. So this patient is having surgery that you probably wouldn't do. I'm going to decompress her ulnar nerve at the elbow, and I'm going to decompress her median nerve at the elbow. That's called a Lacertus release. And it's like a carpal tunnel of the elbow. So sometimes carpal tunnel surgery doesn't get rid of all your numbness, and so you release the Lacertus. And here you see what I'm doing is I'm going from one part to another part, because now every time I reinsert in the previous area, it's already numbed up. So I know she's not going to feel any of these reinsertions. So I scored a hole in 1 on the front and a hole in 0 on the back on this patient. So the whole thing, she felt 1 poke. And that's it. She didn't feel any pain at all during the surgery. And for this, we used to put people to sleep routinely all the time. Now they roll up their sleeve or don't wear one like this lady, and they just get up and go home after the surgery. 0 nausea and vomiting. It doesn't matter if they have heart problems or lung problems or whatever. They just get up and go home. Much safer. So asking for patients for feedback is really important, and this is how I do it.
Right. So I'd like you to please score me while I put the freezing in. Because if I don't know what you're feeling, if I'm hurting you a lot, I don't know. And if I don't know, I can't get better. Yeah. So you're going to feel the first little poke probably when I put the freezing in. But after that, I want you to tell me when the first sting is gone. And every time after that, I want you to tell me if you feel any more pain. Because I don't know if you don't tell me. So you're going to feel this first little poke here. So at the count of 3, I want you to try not to move. At the count of 2, I want you to take a nice deep breath. Can you do that for me? So you're going to pinch 3 times. 1, deep breath, don't move. Great. Thank you so much for not moving. So is that still stinging in there? You don't feel anything? Did it sting when the needle went in? A little wee bit. Okay. So here's what and right now it's not stinging. So can you please tell me If you feel any sting at all in the next 10 minutes,
It's pretty simple. It's a very simple numerical thing. And they either feel pain or they don't. So each time they feel pain, chalk it up to your score. And, look, I have bad days when I'm in too much of a hurry, but most of the time I'm pretty good. I've been playing golf a long time on patience. I can't play golf at all on a golf course. So, and then finally, filler cannulas. This is sort of advanced local, but yeah, that's me. And this is my resident. So this is a blunt tipped cannula, and he's running that up and down my eyelid. We use that to put fillers in patients. And that does not hurt at all because the blunt tip slides through the fat, bounces off the nerves and the vessels. And it's actually astounding how you can do this. And so if you inject local anesthesia through one of these instead of fillers, it really doesn't hurt at all. And so you can do things like facelift. So you make a little hole in the skin and you have your syringe hooked up to an intravenous bag that's filled with tumescent local anesthesia. You slide the blunt tipped cannula around in the fat and they're not feeling any of this. And you put 300 milliliters on each side and 300 milliliters into the neck. And you can go ahead and do a whole wide awake facelift, which I did for years in my office. And all you need to remember is 50. Pretty hard, eh? 50. So 50 mils of 1% lidocaine with 1 in 100,000 is extremely safe. That's 7 milligrams per kilogram in a 70 kilogram adult, although most Canadians are a little heavier than 70 kilograms. But let's say they're healthy and they weigh 70 kilograms. That's 500 milligrams. That 7 milligram per kilogram number was invented in 1948 when lidocaine was invented, long before they could actually measure blood levels of lidocaine in the blood. And now that they can, we know that you can actually inject 35 milligrams per kilogram and have safe blood levels of lidocaine. But the reason that I recommend that you stick with 50 or 7 milligrams per kilogram is because it's ridiculously safe. If you can use 35, you can sure use 7. So that way you really don't need any monitoring. And there are all kinds of papers written about this. You don't need to monitor patients in your office. You don't need to take their blood pressure. You don't need to, any more than you go to the dentist. Do they take your blood pressure there? I don't think so. And it's the same thing. We're using the same drugs as at the dentist. And so that you don't need an EKG monitor and all that kind of stuff. Now, if somebody's extremely frail from a cardiac point of view, okay, you might want to make an exception, take them to the hospital and put them on a monitor. But I'll tell you, that almost never happens in my practice. And if you need to make it yourself, because that happens all the time, we have a current shortage again. And so what you do is you take 0.1 cc's of straight up adrenaline, that's 1 milligram per mil. So you take a insulin syringe and take 0.1 cc's. And put that in 10 cc's of 1% lidocaine. And now you have 1% lidocaine with 1 in 100,000 epinephrine. And if you need more volume, you just add saline. So if I'm doing a facelift, I don't go any higher than 50. I just add a whole bunch of saline and then I put in big volume and away I go. So I'm sure you can do all the little lumps and bumps with 50 extremely safely and not worry about it. For a digital block, if you're doing fingers, you pinch between your thumb and index finger. That's the sensory noise. Middle of a deep breath. Never do the 2 injection technique. That should be gone with the dodo bird. That was invented in 1905, but it's still repeated in some textbooks because it was the first textbook written by Heinrich Braun in 1905. So all the textbooks parroted that for years. But there's level 2 evidence study that a single block hurts less, and you inject in the fat between the digital nerves. Never inject in the sheath. That really freaking hurts. I've had 4 intrasheath injections, 3 on purpose, 1 not on purpose. It explodes, so that hurts a lot. So don't inject into the flexor sheath, just into the fat. And you put in 2 cc's, that's all you need, over 1 minute. There's level 1 evidence in humans that it hurts less if you do it in 1 minute than if you do it in 10 seconds. So is the infection rate higher in your office? Certainly not for soft tissue surgery like carpal tunnel surgery. We published this paper 13 years ago already that where 1,500 consecutive carpal tunnel cases, 9 surgeons, 6 cities, only 6 patients got minor infections. Nobody needed incision and drainage. Nobody needed IV antibiotics for a very safe infection rate of 0.4%, which is the same as in the main operating room. And this is what field sterility looks like. It's a sterile field. You just don't touch things that aren't sterile. And I'm not going to touch my forearm. I'm not going to touch my nose. I'm not going to touch my hair. Everything you're going to touch is sterile. That's what a sterile field is, and that's what field sterility is. That very same infection rate, 0.4%, is the infection rate that Rob Hayes gets when he takes out Mohs surgery in the hospital. So, and there was a series of 20,000 Mohs cases in the United States where field sterility is the standard of care. And they got the exact same infection rate that we did in our carpal tunnel study. So for soft tissue, there's no question that you don't need full drapes and gowns and all that foolishness for surgery. What about for K-wire insertion into fractures? We just published this study, 1,047 patients in 12 cities right across Canada, half in the OR, half in a minor procedure room with field sterility, no difference in infection. It's not about where you do it, as long as you have a sterile field. And this whole thing is called evidence-based sterility. I've written a couple of papers on this. They're available, open access. And we use hydrogen peroxide to clean the skin before and after the surgery. And it's only $1 a bottle. And it works just as well for soft tissue procedures as chlorhexidine, which is $30 a bottle, or iodine, which is $10 a bottle. So if you really want to decrease your infection rates, stop using transcutaneous sutures like these. So these are transcutaneous sutures. These are sutures through the skin. And you see the staphylococcus white pustules there. So why does that happen? It happens, just look at my hands here for a sec. When you have transcutaneous sutures, every time you move, the sutures go and kill the fat underneath the skin by cheese wiring it. So you got dead fat under the skin. And you're providing 2 highways for the germs to go down on your stitches to eat the dead fat. So you're creating lunch and you're providing an access for the germs to eat the lunch. So one of the biggest things that I've done in my practice to decrease my infection rates over the years is to get away from transcutaneous sutures whenever I can. So I like to use buried dermal sutures. So there's no highway into the skin. So you go from deep to superficial, superficial to deep, and your knot is buried deep. And if you go far laterally, the skin kisses beautifully. And I'm going to show you that. And this is what we use for everything. So there I am, deep to superficial. This is after a little lump and bump in the face. Superficial to deep. I go far laterally, about 45 degrees, just like in the little drawing up there. Try not to get any fat in this bite. You just want dermis. And then you don't need to kill the skin when you bring it together, just make it kiss. You know, a suture should be a kiss, not a collision. Do it like you're kissing your grandmother, not like you're kissing your partner, okay? Like just make the edges just touch. That's what you want. So this is the same thing, closing.
I've been using buried 5-0 monocryl sutures for over 20 years. Patients really like not having sutures removed. Also, I'm convinced that it decreases the infection rate because you don't have that highway hole in the skin where the sutures go into the skin. where germs can swim in and eat the dead fat molecules that always happen as the scissoring of the stitch in the dermis and fat kills fat cells. These are deep to superficial, superficial to deep, so that the knot is buried. These are absorbable sutures, simple interrupted dermal sutures. You really only want dermis in these bites. You don't want any fat, if at all possible. Fat has no holding power and just dies. So really evert that dermis. I'm looking on the other side to make sure that I don't buttonhole, and I aim for that flat part of the skin that I can see. They're not really perpendicular to the skin, maybe 45 degrees, but there you see getting a good lateral bite. You don't want a wussy lateral bite, you want a good lateral bite. I'm going in laterally there at least 3 or 4 millimeters before I go deep and exit just below the dermis so that I'm not getting a lot of fat. The other reason not to get a lot of fat is because there are nerves there, and so you're going to end up having discomfort from nerves being grasped with sutures until they dissolve. So deep to superficial, superficial to deep. I'm coming right out just below the epidermis. Then I go right back in at exactly the same height, just below the epidermis. The other nice thing about having buried sutures is when the patients take off their bandage the next day to get in the shower, the sutures aren't caught in the bandage. The bandage just simply comes off. They take the bandage off, get in the shower, and then reapply the bandage after their shower. And at the end of the operation here, we always cleanse with hydrogen peroxide. Let the chemical do the work. Same as getting blood out of your clothing. Hydrogen peroxide's ideal. It doesn't take the color out. And then I always let the patient look at the wound at the end of the case to make sure that they don't faint when they see their wound in the shower the next day. Usually they're very pleased and they say, "Did you actually go in there?"
Right. So here's the dressing that I use for almost everything. I just use skin tape. This is non-sterile tape. You don't need a sterile dressing. You just need a clean dressing. And it's just micropore paper tape, and it's brown skin colored. So on the face, it kind of looks nice. They get in the shower with these, whether it's on their face or their elbow. And the only thing they wear is the skin tape into the shower. And at the end of the shower, they just let the skin tapes air dry, and they take them off at anywhere between 7 to 10 days. And that's it. That's the dressing. Paper tape is a lot less expensive, and you certainly do not need a sterile dressing. There's absolutely no evidence that that makes any difference. Now, to do most soft tissue surgery in your office, you only need 5 instruments. You only need a pair of forceps, a scalpel handle, a pair of dissecting scissors, needle driver, and a pair of suture scissors. That's it. That's all you need, and a little bowl for your hydrogen peroxide to prep with. So I prep with hydrogen peroxide, clean with hydrogen peroxide. I've been doing that for 35 years, and there's no evidence that you need iodine or hexadine for the lumps and bumps you do in your office. Now, if I need extra instruments, I have them sterilized separately. So you might want skin hooks, or you may want retractors if you're taking out lipomas or that type of thing. And so you can have those wrapped separately. And I would never put in a ceiling light if I built an operating room again. And I would never buy a pole-mounted light. They're like dinosaur stuff. Go to Amazon, buy yourself a headlight. That's going to work just fine. I know 2 hand surgery program directors in the United States who use Amazon headlights for their surgery every day. This is the headlight that I use every day. This one is $2,000. These guys are about 40 bucks. So, and they're just as good. But Amazon didn't have these when I bought these. And I didn't have Amazon when I bought this. So, but that's what I would do today if I were you. And you can have any room to do surgery. You do not need special ventilation. If you're doing a total hip or a total knee, that's the only surgery where there's good evidence for room ventilation. Other than that, you'd be amazed at how little evidence there is on sterility. But the only good evidence for ventilation is if you're putting in total hips and total knees. Certainly not for any of the stuff you're going to do in your office. That happens to be the room at St. Joseph's where we do lumps and bumps. This is what my office looks like.
This is the waiting room of Dr. Lalonde's office. After the patients are injected, they wait in here for at least a half an hour for the carpal tunnels or trigger fingers or whatever else they're doing to numb up. These are consultation rooms, little hand consultation room where we see patients in between the surgeries so that we're not wasting any time. This is the first of our 2 procedure rooms where we inject people lying down to decrease the risk of fainting. We do minor procedures such as carpal tunnels in here. We are now going into the larger of our 2 procedure rooms where we do bigger procedures like tendon transfers and so on, but also minor procedures. There's an overhead light that I hardly use anymore. Now I almost exclusively use a small headlight to do all of my procedures. There is a small cautery machine that is available, but we almost never use it for wide awake hand surgery.
If you wait 30 minutes, you're not going to need cautery for most things. On the occasional bleeder or hypertensive, you might, in which case you can go ahead and use it. I just want to say a word about safety here. So this fellow had metastatic lung cancer and he lived 6 months after I did his surgery. And I knew he was going to die. So why did I operate on a guy in his 80s who was going to die? Because he couldn't sleep at night. His carpal tunnel was keeping him awake. And over on the left there, you see another human standing up during the surgery. That's his daughter watching him have surgery, sitting there with his oxygen on. That's how he sleeps, sitting up with his oxygen on. And 6 months after he died, she wrote me a beautiful handwritten letter, which is something that people almost never do anymore. And she said, I just want to thank you for letting my father sleep for the last 6 months of his life. He was so grateful that he could at least get sleep at night. And it's totally safe to do this stuff. Like, you can take people who are really sick and you should never subject them to sedation. I would never ask my anesthesia colleagues to put a guy like this to sleep. I mean, that's just, in my view, bad medicine. So, but straight up local, you can do pretty much anything to anybody. So a couple of other office tips. Get a nurse, okay? It's like, get a life, would you? A lot of doctors don't want to get a nurse. They pay for themselves. They get rid of all of the seeing people undressed of the other sex issue, if you happen to be male especially. They can do your instruments, help you in the OR, coordinate your operating room schedule. It's just so helpful to have a nurse in your office who can do all these things. And if you're doing things like cysts, you got to take out the block pore and all the cells that make the oil. You don't need a big margin. And usually if the skin is attached to the cyst, I just leave that part and just go around it where it's loose and then just tie it up. Now, basal cell skin cancers are usually pretty obvious. This one, you can see the edge well. You could get a 5-year-old to draw around that with a crayon and he'd get it. So if you can see the edge well in a basal cell, histologically, they go straight down. And basal cell skin cancers don't kill people, right? Because they don't swim. They don't metastasize. So the only sin there is you don't cut the whole thing out and then you have to do it again. So if you can see the edge well and you take a 3 millimeter margin, you're going to cure that sucker. So good for you and good for the patient, especially if you're in a community where it takes forever to get a surgeon. Now, if you can't see the edge well, histologically, they do that kind of stuff under the skin. And so you'll frequently get an incomplete excision margin. And so that's when you got to kind of go big or stay home. So you might want to refer that to either your friendly neighborhood plastic surgeon or a dermatologist. Malignant melanoma, you probably don't really want to tackle those. If you see something like that, you probably want to pass it on. But again, if you're in a community where it's going to take you 4 months to get somebody's attention, look, you could take it out in your office, take a 5mm margin, make sure you get the whole thing, make sure you get 5mm deep. And now that it's biopsy proven, you're going to get their attention, but go big or stay home if you think it's melanoma, or refer it if you can. For just a plain ordinary nevus, anybody wants that thing off their cheek. You can't blame them for that. And you don't have to do a lens shape excision. Like here, I'll go right on the nasolabial full crease with this one, and I'll kind of bunch that in there. And on the nasolabial full crease, you can really hide it. I'm not going to give you a lesson on how to do surgery here. I'm just giving you the principles of how to start it in your office. There's all kinds of videos. Go see Dr. Pimple Popper. There's good videos on how to take things out. And this isn't a surgery course. This is a how to start surgery in your office course. So there are two common problems that you're going to see in your office. You're not going to see allergies. Allergies to local anesthesia are extremely rare, if they happen at all, to lidocaine. Just don't use bupivacaine, by the way. It sucks. Bupivacaine, ropivacaine suck. The long-lasting local anesthetics, because the pain part comes back twice as fast as the numbness part. So the pain, there's level 1 evidence in humans that if you do digital blocks with bupivacaine, the long-lasting one, that the pain comes back in 15 hours, but the numbness comes back past 30 hours. So if you use bupivacaine, the patients are going to show up to the emergency department the following morning, and they're going to say, "Doctor, my finger hurts, but it's still numb." And the emerge doc, who doesn't know that bupivacaine has this problem, is going to go, "This guy's whack job. He says his finger's still numb, but it hurts." That's the way it is with bupivacaine. It's not a light switch like lidocaine. Lidocaine, when it comes out, the numbness comes out, the pain comes out, the touch and pressure and temperature all come out at the same time, not bupivacaine. That's the first reason I don't like bupivacaine. The second reason I don't like bupivacaine is if you get an intravascular blast of lidocaine, who cares? Lidocaine is what we used to use in cardiac arrests all the time. It's cardiac protective. And even epinephrine is a coronary vasodilator. Okay, the guys who are doing these angioplasty things, when the heart stops, what do? They put adrenaline into the cardiac coronary arteries. So small doses of epinephrine are actually cardioprotective. And so if you get a little blast of lidocaine with adrenaline in your vein when you're injecting tumescent local anesthesia, notice I never drew back. I could care less if I get a little bit intravenous. In the emergency department, if they have total body trauma, multiple trauma, some emergentologists are giving 100 milligrams of lidocaine IV slowly to take away all the pain everywhere. And so you can tolerate 100 milligrams IV slowly. You can tolerate a little blast, okay? It's not going to hurt you. Bupivacaine, if you get a blast of bupivacaine, that's another story. There's a kid who died. He was 5 years old, having an autoplasty, just having his ears pinned back by a plastic surgeon because he got a little blast of bupivacaine, because it stops the heart for a long time. It goes between the SA and the AD node and stops the heart. Now you can rescue that with intralipid, but who wants to? You want to pump forever while you're pouring intralipid into somebody for something they didn't need, and you don't need that long local. So anyway, don't use bupivacaine, it sucks. So, but there are two problems with lidocaine and adrenaline. Allergy's not one of them. But they will get an adrenaline rush. Not all of them, but a lot of them will. We did a paper and found that it was only 3%. That was done by one of the residents in Newfoundland. I know it's higher than 3%, but that's what he found. And hey, that's what they found. That's what they found. That's what research is. So, but I warn each and every patient, look, you might get an adrenaline rush here because I'm putting adrenaline in with the lidocaine so that I can see better and so that it can last longer. And so if you feel a little shaky or like you've had too much coffee or like you just turned around in your car and saw a polar bear sitting in your back seat, it's not your nerves. You're not nervous. It's me. I did this too. It's the drug. And it's a normal reaction to adrenaline. And the little adrenaline rush that you get, if you get it, is going to go away all by itself in 15 or 20 minutes. And you are not allergic to it. So I tell each and every patient that it's like singing the same old song. The nurses get bored with hearing me sing the same song all the time. Now, the second problem people get is they might faint. You just pull out your needle. That's why I don't show them the needle usually, especially if they're needle phobic. But I turn my back and I pinch the skin and do all that stuff that you saw most of the time, and they don't see the needle going, especially little kids. But fainting happens when you take a bandage off. Fainting happens genetically in some families. There's a whole thing out there. Google fainting goats. There are species of goats that if you go out in the field and clap, the whole herd faints. So fainting is one of those things we don't understand, but we do know that there's not enough blood going to the brain. And the nature's way of fixing that is boom. So that's the problem. So to avoid the problem, you always inject them laying down. Well, we'll get to that in a minute. Let's start this video over again. So this video was taken by some German neurologists in 1994. And they had 56 people in their 20s who induced fainting. And they induced fainting by hyperventilating, squatting, and holding their breath. And that will induce fainting in everybody. And so they had 56 people induced fainting. So I'm going to show you a few of these, and all of these people are fainting. They are not having seizures, okay? But when you look at it, it kind of looks like a seizure, doesn't it? Now, 10% of them don't move at all, but 90% of them have these myoclonic jerking movements, sometimes symmetrical, sometimes not. That was a symmetrical one. This one's a little more asymmetrical. But the nurses see this and they go, oh, he's having a seizure. And you're going to go in and go, no, he's not. He's fainting. And even their eyeballs roll up. Look at that. Look at those eyeballs roll up. That's a faint. It's not a seizure. Same with hers. Okay, so how can you tell the difference between a faint and a seizure? All these young people recovered consciousness in less than 17 seconds. The other big thing, the biggest thing, is when they recover consciousness, not only is it very fast, but when they recover consciousness, there is zero confusion. Like all these kids, they would say, count to 10, count to 10, count to 10, while they were having their seizure. And as soon as they heard and processed the words count to 10, they started counting to 10 in German. And as soon as they stopped twitching, they'd go 1, 2, 3, 4. So they understood count to 10 and started counting to 10. Their brain is totally clear after a faint. And a faint doesn't last more than 17 seconds, and there's no confusion. So, but the most powerful thing is there's no post-ictal confusion. And obviously there's no incontinence. Sometimes when people have a seizure, they pee and all that, right? So certainly that's not the case. So that's how you recognize the difference between a faint and a seizure. So don't ever label these people as having seizures so they can't drive. That's why I'm showing you this video, so you can educate yourself about this. So always inject people laying down so that you decrease the risk of it happening because there's more blood going to the brain. If people tell you they're fainters, then definitely laying down and with their knees up. Now, when people say, I'm not feeling very well, or I think I'm going to be sick, or they get pale between the eyes, or they start to yawn like this lady in this video did, because this is a real-time event. This actually happened. And so I said to the medical students, start shooting. I want you to film this. So the first thing I do, hand under the knees, lift up the thighs. There's 2 liters of blood in the thighs that goes straight to the brain. More blood to the brain. Take the pillow out from under the head, I don't care if it's uncomfortable, and put it under their feet. More blood to the brain. Then go up to the stretcher, and in your office, you ought to have a stretcher that does Trendelenburg. This is what Trendelenburg is. The Trendelenburg position is head down. Now you got more blood to the brain. And this was a real-time event. You saw how long it takes me to do that, no more than 10 seconds. And I do it quite a bit. So you have to be ready to do that. And then you can let the nurse run for the cold, wet face cloth, which does absolutely nothing for cerebral blood flow. But that's what Florence Nightingale said to do 1,000 years ago. So that's what they all do. So that's how you abort the faint. If you don't do that, they're going to do the twitch thing and they're going to make it look like they're having a seizure and they're not. But that's just because you were too slow getting the blood to their head and you didn't recognize the signs. So that's the end of what I'm going to talk about. These are my puppies. 2 of them are still left, the 2 puppies. And I'm going to stop sharing my screen and answer any questions if anybody has any.
Don, that was great. That was a fantastic lecture. I mean, you could probably market that and sell that online, I'm sure.
Oh, thank you.
So listen, I'm just going to open it up to a few questions if anybody has any. I see right here, Ben, you go right ahead. Oh, Ben, you're clapping.
I was clapping. Give me a second here to come up with a question.
You don't have to, Ben, but that's okay. Thank you for the clap. I appreciate that. I know it's a lot of information to throw at people, and it's okay if you don't have questions. I'm okay with that.
Well, just wait for a sec, Don, but can you just comment for a second? I think these guys would be interested to know how much and how often you go across the pond and what you've done over the years.
Yeah, so, well, I started going overseas with Operation Smile to do cleft lips and palates. And I started that in 1996, and I've done that in more than 25 countries. Some were repeats, but I've been over 25 times, 2 weeks a shot. You know, at least, well, a lot of surgery. So, and then I transitioned from cleft work to hand work and now wide awake surgery work. And so I'm helping general surgeons and orthopedic surgeons from all over the planet, especially through Zoom. You know, I've Zoomed in over 150 countries. I have been to, most of my work is now concentrated in Africa because that's where people can't afford surgery. And they certainly cannot afford unnecessary general anesthesia or sedation. And they can't afford main operating room sterility for a lot of operations that you don't need it for. And so we're making surgery affordable and available. And most of my work has been involved in Kenya. And the reason for that is because Kenya is like a bellwether country. The surrounding countries like, you know, Malawi and Ethiopia and Uganda and all these places that are around Kenya tend to emulate what the Kenyans are doing in medicine. So if the Kenyan doctors, surgeons, anesthetists are doing stuff, they kind of want to do that. Oh, they're doing that in Kenya, you know. And, you know, not that they're not doing it in South Africa, they are, and they're doing it all over Africa. But so in Kenya, we've established now over 15 hospitals where they have started wide awake hand surgery or wide awake surgery. It's not just hands, they do everything. Outside the main operating room with field sterility in 17 hospitals. and that is growing. And it's in several other countries. I know that there are at least 15 countries in Africa where they're doing wide awake surgery. In Ghana, for example, we started a wide awake surgery room there in 2017. They're doing over 500 cases a year in that room, and it's half the cost for the patients of Kumasi, Ghana. And it's spreading around the rest of Ghana. But this has gone to Nigeria, Algeria, Morocco, Egypt, South Africa, Rwanda. I was in Rwanda for 2 weeks in February. I think that's where we talked from, I talked to you from Kenya.
Yeah.
We did a course in Kenya where we had surgeons from 10 surrounding countries come and see wide awake surgery in Mombasa, Kenya. And we had surgeons from, I was the weird Canadian, but we also had an American and a guy from England and another surgeon from Malaysia come to teach this wide awake surgery stuff to the 10 countries surrounding Kenya. And we're getting to the critical mass point where, oh my God, look what they're doing. Look, oh my, they're doing it over there. Oh my God, look, people can afford surgery now. So if you're a farmer and you cut your tendon or you break your hand and you have an unstable fracture with a crooked finger, you can now go in and get fixed and go back and be able to farm with 2 hands so you can feed your family. Whereas before, they would show up. The first time I went to Ghana and sat down with a bunch of surgeons, the surgery resident showed one view of a badly displaced radius fracture on Monday morning. And he got bawled out by his attendings who said, "Where's the lateral view?" And the resident said the patient could only afford 1 x-ray, doctor. And he knew damn well that his attending knew that. They were doing that for my benefit. Because patients come in and they either walk out because they can't afford an x-ray, or they go, "I'll pay for 1 x-ray. That's all you got because it's going to cost me a week's wages." And so that's the reality of life over there. So if you eliminate unnecessary BS, like sedation that you don't need, and if you eliminate unnecessary sterility, because it doesn't improve the infection rate at all for many procedures, all of a sudden people can afford surgery. So that's what I do.
That kind of brings it home for everybody, doesn't it? The real life, what they can and cannot get, and what we're spoiled with here.
Yeah, we're pretty lucky here.
Yeah. Ben, you got a question?
Oh, I do. I'm a bit dark. I apologize.
No, that's all right. We got you.
Excellent. Thank you very much, Dr. Lalonde, for your talk. I'm Ben. I'm a 2nd-year student at the Dallas site in St. John. My question kind of follows along that same sort of resource stewardship angle that we were just talking about. And I guess it's interesting. It's the second time in a couple of weeks I've heard someone mention doing like a total below-the-knee amputation under local, which sounds wild. But it's really neat that that's something that can be done and can then, as we're talking about access, increase access to care in places without the same access to resources. My question is a bit about like where is the trajectory in terms of even doing like your own anesthetic work in plastic surgery, where I guess I'm sort of struggling to I don't really know where the line is between doing like anesthetizing like cutaneous nerves and sort of irrigating around, you know, the site where you're going to do an excision. Where is the threshold in your practice where then, like, if you were doing a tendon repair or something like that, when would you then go like more proximally and do like a nerve block farther upstream, and like how far can you go with that sort of local cutaneous irrigation stuff?
Yeah, no, that's a great question, Ben. So clearly you can do below knee amputations. In fact, the first case reported in the world literature was by a fellow called Asif Admani, and he lives in Mombasa, Kenya, and I helped him publish it. I went there and he said, well, yeah, we did it, and we got videos, and you know, this wide awake stuff is great, Dr. Lalonde. And so I said, look, you got to write this up because nobody's ever published this. He said, I don't know how to do that. And I said, well, I know how to help you. So it just got published this year, and there's you know, you certainly can do that. I don't believe in nerve blocks. I think nerve blocks are fine for little nerves. But we did a study where a number of your ancestors at Lalonde, New Brunswick, and I got bilateral median nerve blocks. So 10 medical students and me, and maybe you heard about it, Ben, I don't know if you did or not. So we all got bilateral median nerve blocks. Again, one of the medical students injected mine first. I was the first guinea pig. And the goal of the study was to show that 10 cc's work better than 5 cc's. Duh. But what we found was way more profound than that. What we found was that it takes 100 minutes for the lidocaine molecules to get to the center of the median nerve. The bigger the nerve, the longer it takes for the lidocaine molecules to get to the center of the nerve. Because we poked ourselves with sharp needles every 10 minutes, and as long as it was getting more and more numb, we knew that we were getting more and more of the nerve. So that's how we found that out. But 100 minutes, that's a long time. The bigger the nerve, the longer it takes. And that's why so often when anesthesiologists do axillary nerve blocks or infraclavicular nerve blocks, they don't work. They don't work because we don't wait long enough. And so, frequently there are failures of these blocks. But if they inject them and park them for an hour, then it works. But they have to adjust their timing to get it to work. So, you don't need to wait that long, Ben, because you don't need big nerve blocks. You only need big nerve blocks when you get like a spaghetti wrist. So if somebody cuts their forearm, boom, like that, right? So I blow up tumescent local anesthesia all around so that I can do whatever I want with the skin flaps. And the first thing I do is go in and find the median nerve and lift up the epineurium, the outside part of the nerve envelope, and take a 30 gauge needle on a 3 cc syringe and blow up the epineurium of the median nerve like a hot dog on a stick. And that's the first thing I do after I get in the skin. And so because it's right in the epineurium, blowing it up like a hot dog on a stick, it numbs up the nerve pretty quickly. You never want to stick a needle into a nerve, okay? Like when I was a medical student, I was taught, if you want to do a nerve block, stick the needle in the nerve till they go, ouch, I feel electric shocks going down my median nerve. That's a really bad thing to do. You never do that because you're going to lacerate fascicles and cause nerve damage. So you never do that. And so you blow it up like a hot dog on a stick. And then you fix all the tendons, and then by the time you fix the tendons, you can coap the nerve and they don't feel a damn thing. That's how you get around the 100-minute problem when you're doing nerve repairs in a proximal, forearm or upper arm nerve that's cut. So I don't believe in nerve blocks. I believe in tumescent local anesthesia. And I believe that you can do many, many, many things with tumescent local anesthesia. You can certainly do hernias. You can even do bowel reanastomoses. You can cut and sew the bowel with no pain. But if you pull on the bowel and get peristalsis, they're going to feel cramps. Harvey Cushing knew this. He was the first surgeon in 1900. So if you blow up the abdominal wall, you can go in and do stuff in there as long as you're not pulling on the bowel and causing cramps. And you can operate on the brain. I mean, the brain surgeons knew this 100 years ago. The skull is numb. When they talk about numbskull, they're quite right. You can chisel and burr the skull and they don't feel it. I've done that a number of times just to cover wounds when the skull is exposed. It looks like rock. Anyway, really, I think the true answer to your question is we're just beginning to learn about this stuff. And I know that tumescent local anesthesia will replace general anesthesia and sedation for many operations that we're doing in 2023 asleep. Certainly most hand surgery is going to be replaced with tumescent local anesthesia. There's no doubt about that. And it's happening all over the planet, even in the United States where they make more money doing it asleep in hospitals. That's a political problem. The insurance companies own the hospitals and they're a big dragon that they need to feed. So even though it would cost people who pay insurance less to have it done wide awake, they don't want to do that. They need to feed their dragon. It's a political problem. It's got nothing to do with patients. And if any American was sitting here, they would go, yeah, I know. It's sad, isn't it, Don? Yeah, I know.
That's great. Thanks, Ben. I know we're running late in time here. Just if there's any other burning questions, I think we'll bring it to an end here. So Don, once again, fantastic lecture. I know you really tickled some feathers here with these guys, and you may be getting a few more requests for electives, and that's your fault. So I'll leave that part alone.